Okay, welcome everybody, and thank you for attending part 3 of the cultural series. And this is brought to you by Brown County Dementia Friendly Coalition. We have a subcommittee of that coalition that works to provide educational opportunities for the community wherever you are and on various topics. And so this fall, we decided we would talk about cultural elements within dementia. My name is Debbie Miller, and I'm the Dementia Care Specialist with the Oneida Nation. And I'm also joined by a committee member, Laura Nolan from the UWGB, and Virginia from the Alzheimer's Association. Before we introduce our speaker, I just want to let you know that you'll be on mute, and we will unmute you when the questions and answers start, and that'll be at the end of the presentation, or you can put your question in the chat. So Virginia, if you want to introduce our speaker.
Yeah, of course. So Al and I have known each other for a long time, and he has a master's degree and a social worker degree, and he's the program director of the Health Research Department at the United Community Center in Milwaukee. He has been with the UCC for over 20 years, and the UCC is a large multi-services Latino nonprofit community organization serving the range of preschool age to older adults through various programs in the area of child care, education, programs for youth, substance abuse treatment, elderly services, low-income housing, fitness, health, and neighborhood development. They have a cute little gym in there at the UCC. I have used it. So with an annual average budget of over $26 million, the UCC is able to serve 16,000 to 18,000 individuals annually through over 4,000 staff among its various programs.
400.
1,000. 1,000? What, how much did you say?
400 staff.
Oh, 400. I think there is a zero added.
Oh.
That's why I said, wow, 4,000.
Wow.
But okay, 400, I stand corrected. 400 staff, which is more realistic, right? That work in throughout all of the departments. The majority are from low-income status, over 95% Latino, and range from natural citizens to immigrants from various Latin American countries or backgrounds. Mr. Castro serves as a primary liaison with the research universities, developing and maintaining collaborations and partnerships for effective community engaged research in the Latino populations of Greater Milwaukee. UCC collaborates with various academic research universities, such as the Medical College of Wisconsin, UW-Madison, Marquette University, UW-Milwaukee, and Carver University, in conducting community engaged research in areas of health issues and inequities among the Latino community. It leads at the development of programs and services that addresses these issues and needs. Mr. Castro has been a co-author in various published health research articles related to these community health research projects. Prior to his position, Mr. Castro has been the program director of the UCC Latino Geriatric Center, which is composed of a memory diagnostic clinic for Latinos and an adult day center designed for Latinos with dementia care needs, and to provide support to Latino family caregivers. Mr. Castro has over 25 years of prior experience as a social worker in county human services programs, in Milwaukee County Human Services programs, including child protective services, juvenile services, and adult services. Mr. Castro has a master's degree in business management from Cardinal Stretch University, a bachelor's degree in social work from Kerbal University, Waukesha, and is a licensed social worker in Wisconsin. There you go, fantastic. So now you have the floor.
Thank you.
You're very welcome, thank you.
It's good when he's at 4,000, there goes our payroll.
My bad.
I gotta correct that. Thanks for catching that. Gracias.
No worries.
Thank you. Well, muchas gracias. Thank you for inviting me tonight. I've been asked to share, I guess, our experience at the United Community Center from the Latino perspective, but also from the provider perspective on dementia in the Latino community. So tonight I'm going to share with you on how we're responding to the dementia community, the Latinos and dementia in this community. And I'm going to share with you some, not just what we're doing, but I want to start also with who we are, Latinos, you might say, in Wisconsin. So I have something I want to share with you here. So I'm going to call this Responding to Dementia in the Latino Community. Presented specifically just for you folks. And hopefully everybody can see this, right? So I'm going to cover, Virginia already covered the introduction of UCC, so I won't spend too much time on that. I'm going to walk you through where, I guess, an overview of Latinos in Wisconsin, population-wise and demographics, and then touch upon some relevant health issues that impacting health for Latino, because we all know how healthy a person is or unhealthy can lead to either good brain health or brain health, which leads to dementia symptomology. I'm going to touch on how Alzheimer's disease and related dementias in relation to our norms and our values and what we as providers need to be aware of, how this interplays with detection, diagnosis, and accepting of services. And then I'm going to walk with you on how we responded to this issue in the Latino community starting in 2007 in partnership with the Alzheimer's Association. And then leave the last 15-20 minutes for questions and answers. Okay. Virginia touched on this already, but we're a nonprofit, and that's our mission statement up there. It's kind of outdated because there it says near South Side residents of Milwaukee. Right now we serve the entire county of Milwaukee. So I guess we're going to be reviewing this mission statement this coming year, but we are county-wide now, even regional now. But we're still serving in the areas of education, cultural arts, recreation, community development, health, and human services. And that's our website. And that's one of our many buildings there. That's our primary building, main entrance. We've been around since 1970, so we just observed our 51st year. We're one of the older Latino organizations in Milwaukee. And she already touched all this. And our executive director, we have a new executive director. She started about the month before the pandemic hit, so she hit the ground running, Laura Gutierrez. We're very proud of her. She's really held us together, and we really love her because she's one of our youth that grew up in our programs here. Went to our youth prevention program. She was a youth counselor and came back to work here as a teacher, then became like a principal, went off, got worked somewhere else for the government for a while, and now she stepped in executive director. So she's come full circle. So we're proud to see, and this is what we're about at UCC, trying to grow these future Latino leaders. But she also went to Carroll College. Ta-da! Had to put that in there. Stepping back, kind of frame, this issue was dementia in the Latino community. What is the Latino community in Wisconsin? And I pulled this from the recent census, so some of this is still being filtered out. So I'm just saying estimate because some might change over time. But the latest estimate, was 418,000 and some Latinos in the state of Wisconsin. And like I say, these are the ones that answered the census. So there's probably many more out there that are not going to answer the census. What's of note, though, and Virginia's probably aware of this is the first time the census finally agreed to put in an ethnicity question for us. It's always been, we had to choose between Black, White, African American, American Indian, Asian Pacific. There was never a Latino, Hispanic question before. So some people like myself would just leave that race question blank or put other because we don't identify as white. So that's, that can multiply over time because you're miscounting the actual number of brown-skinned people that call themselves Latino, Hispanic, whatever, things like that. So this is the first time they were able to do that. So we could capture a little better idea of the actual Hispanic population in the United States and in Wisconsin. And again, those who answered the census. Not surprisingly, Wisconsin is still pretty much white dominate population. The Black population has grown 6.7. But what's interesting is the Latino population has finally passed the African American population in Wisconsin. We are now the second largest minority population in Wisconsin. American Indians grew. Asian American is a fast growing population. Keep an eye on too. They're 3%. If you look at the right hand column of that slide, I want to highlight that the growth rate. Now, this census was done for the period 2010 to 2020, right? So we jumped from 330 some thousand people to 418,000 people. That's like a 30% growth. Something to be aware of as service providers, as educators, health, social service providers, business people. It's a growing population. And I want to remind you that in the prior census from 2000 to 2010, Wisconsin Latinos showed a 74% growth rate. So that's amazing, isn't it? So it bears repeating that it is a fast growing population to be aware of and monitor and respond to needs to. So I appreciate these kind of webinars. Obviously, you folks are ahead of the game by wanting to get more information about Latinos and dementia in the community, because we will see it just as much as in other populations. Oops, went too fast. Brown County, I don't know if you knew that, but you had a big jump too up in Green Bay area. Latinos are now your second largest demographic behind whites at 26,000. So that's a 45, almost 46% growth from 10 years ago. So this is a time to have these kind of conversations with your community there. So stepping back and looking at those health issues that I think are relevant to the Latino population in comparison to the Anglo population that can lead to poor health outcomes and obviously dementia symptomology. I just pulled some of these up from this study that was done in 2013, is completed by the National Health Interview study. We have 35% less heart disease and 49% less cancer rates than the white population. I'd be interested to hear comments in the conversation later why you think that is. A lower death rate overall too, but however, a higher percent of death due to diabetes. And I'll have a little more about diabetes later. About a quarter have 40 control high blood pressure, almost a quarter obese, and a little over a quarter are not going in for colorectal screening. Interesting too, Mexicans and Puerto Ricans are about twice as likely to die from diabetes as whites, and we've known that, those of us who work in the community and those of us runs in our families. Also, between this group, Mexicans are twice as likely to die from chronic liver disease as compared to the white population. Smoking. Most Latinos don't smoke as much as the white population, but the ones that do tend to be the Puerto Ricans and Cuban males. But even then, it's less than about a quarter compared to others. I mentioned this before, the screening rates can vary by population. And what I found with the Cubans, it's different than Cubans and Puerto Ricans about the screening rate. But here it goes back again. Hispanics are likely to have high blood pressure. And again, I point that out because this is one of the high risk factors to develop dementia. Just like white women, Anglo women, Hispanic women are better at controlling high blood pressure than Latino men. We men just don't learn our lesson no matter what culture we're from, right? Let's see, I think I went the other way. Okay, here we go. I just want to call out one here. The second bullet down, compared with US-born Hispanics. Foreign-born Hispanics have, now again, this is comparing US-born Hispanics like myself, foreign-born Hispanics like Virginia, right? Those coming from other countries tend to be at half as much as heart disease rate, less cancer, less blood pressure, a little more high cholesterol than others. People call this the Latino Paradox, right? The health paradox. If for some reason Latinos from other countries come in healthier until they discover McDonald's and fatty food and things like that, then they've joined the great American dream by developing high cholesterol and blood pressure. So something to be aware of there. Education level, social factors can, like anybody else, inspect health, but it's especially we see in fact Hispanic health, and this is Virginia's area. She's a public health specialist. Literacy is a big issue. Lack of education, lack of reading skills, poverty level living. It all impacts somebody's ability to understand what's going on around them about their health and prevention of health and accessing health resources, it just kind of snowballs there. So the literacy and education level is a major concern. I pulled this slide out because I pulled it right out of the study, but it's a side-by-side comparison of non-Hispanic whites versus Hispanics about chronic disease burden. And the one I want to call was one at the bottom there, the poorly controlled high blood pressure. That about 50% of non-Hispanic whites are do a poor job controlling blood pressure, but 68% of Latinos aren't doing that either. So there's a higher rate. And we see that in our memory clinic when we do our screening. We do see a lot of high blood pressure not being managed well. And we all know that's another risk factor, right, to develop dementia. This is always an interesting one. This is the death, 10 leading causes of death. And this is comparing non-Hispanic whites versus Hispanic. I didn't look at the other population groups. I just looked at Hispanics. You can see the number 1 and 2, they kind of flip around between the white population and the Latino population. But when it starts varying in the next ones, Latinos tend to die more from unintentional injuries. We believe that's due to the kind of jobs that many people do. They're high-risk jobs. They're farm worker jobs. They're up on roofs. They're cutting trees. Maybe poor driving skills. I don't know what it is. I don't know if that includes homicides or not. I'm not sure, but it's unintentional injuries, which is not as high in the white population. The next one that I want to call is that diabetes. I'll keep going back to that. This is just like in the African American population, this is a chronic disease that impacts so much of our health and the after effects of that. So again, higher than the white population. Alzheimer's disease, not as high as the white population, but again, part of my presentation is it because we're not asking, we're not screening, we're not detecting earlier? I think we get better at it. We'll probably get better at capturing that kind of data and diagnosis. That's for your information. So we'll bring it down to Alzheimer's. And some of this for Gina Green-Harris, those of you who saw her presentation touched on, so I'm not going to repeat a lot of what she said. I just pulled out a couple of things that she said just to reinforce that in case you didn't hear it. Older Black and Hispanic American. By the way, in my presentation, I'll go back and forth between Hispanic and Latino, Latino and Hispanic. So bear with me on that. We go back and forth in the conversation, but I'll go back and forth on it. Again, more likely to have dementia than the white population, and Latinos 1.5 times more is the risk factor. I'm the prevalence. There's a new study that's still coming out. It's still in press. I was looking at it a couple of weeks ago. It's called the CHAP study out of Chicago Health and Aging Population. For how many thousand? I think they talked about 3,000. They did 3,000 or 5,000 diagnosis data they were looking at. They're showing that about almost 19% of Blacks and 40% of Hispanics age 65 and older have developed dementia, Alzheimer's dementia, compared with 10% of the population. I mean, we kind of know that, right, Virginia? We kind of know that, but to see somebody actually saying yes, and this is even more current, that gap is starting to widen now. 18% is almost double of 10%. So it's something of concern to the Black population and 40% for Latinos. And I think as we get better at diagnosing and screening, we might see that even better, as more memory clinics and diagnostic tools are out there that can do testing in Spanish. I'll be curious about what the final report's going to be on that. Keep an eye on that one. I want to talk about what gets in the way of Latinos having their needs met when they develop dementia or a family member in their system develops dementia. Some of this is well known. I've been repeating myself, and Virginia knows this just as well as I do. The language barrier, and I put both ways because it's not always on the patient's fault. By that I mean is we don't have as many Spanish-speaking primary care doctors, Spanish-speaking neurologists, Spanish-speaking psychiatrists, geriatricians, nurse practitioners, on down the line. Those people that are in the front line, they can catch dementia symptoms earlier, they're not there. So they depend on interpreters, or maybe the patient doesn't feel comfortable sharing this with the English-speaking physician or nurse, things like that. And as I mentioned earlier, the information is not always out there in time in the language that they understand. Or the next bullet, at the literacy level that they understand. Something to be aware of is our population is just because someone speaks Spanish fluently does not indicate that they necessarily know how to read it and write it. Especially if I'm older adults that came from other countries, or like in myself from rural Texas, where the education system was not as strong, people maybe didn't go to school at all or dropped out after first, second grade to work and never learned how to read it and write it. They can speak it. So even just handing out brochures in Spanish or putting things in the newspaper in Spanish doesn't mean that they're going to understand. So we're missing, so the literacy level has to be accommodated and accounted for. The acculturation level also can be a barrier. The more time a person has spent, like any other culture, the more time you spend in this country and the more generational presence you have, the more you become able to access information and hear information that you understand, learn how to look for information, accept outside help, learn how to work social media, the digital information that's out there, and then accepting of offers for screening and things like that. So it makes a big difference on how long somebody has been here and how many generations have spent living here in Wisconsin. It goes without saying, people that are insured have much more access to early prevention, early diagnosis compared to the uninsured or the underinsured. Until the Affordable Care Act came around, people might have had insurance, but didn't cover everything. It was too expensive. And to this day, it still exists, right? They may have insurance, but high deductibles. Those high deductible premiums will keep people from using the insurance. So that's always a factor that gets in the way of any low-income community, and even so in the Latino community. What's unique for us and probably some other population groups is the status of documentation here. If you're someone who's here undocumented, we have people living in the shadows all over Wisconsin here that are uncomfortable or unsafe about stepping forward and asking for help or allowing help to come into the home for fear of being deported or reported. Or maybe they themselves might be documented, but a family member may not be. They might have a relative living in the home, a friend living in the home that's undocumented and fearful to have anybody come and talk to anybody in the family about what's going on with the father and the mother having memory issues. And even then, even if they get diagnosed, then trying to get services for them is a major mountain. They're not eligible for Medicaid, Medicare, government-funded services. So having to rely on the social network and the charities that exist in the community. So it goes beyond just being screened and tested. It's then so what after that, what services are available? And then it's not much for the undocumented. We've run into cases like that many times. I want to go back to this earlier detection, the language barriers. And we know that it's getting better now, but the earlier primary care doctors that were trained some years ago were not trained in dementia screening and symptomology. So they were missing symptoms also they could be asking about. The hopeful thing is I see new medical students being trained in younger doctors. They are getting better trained and screened to screen for memory issues than compared to the prior generation of physicians. But even that, as I go back earlier, we still have a shortage of Spanish-speaking doctors and physicians and the whole healthcare field there that can lead to missing symptomology about potential cognitive decline that would need further evaluation. There's also financial costs. People, like I said, they may not have insurance, or even have insurance. What do they have to pay out of copay or the deductible? Which for a family that are just just breaking even is extra cost. Or if they have to pay for somebody to come and stay with grandma or grandfather in their home while they're at work, because they can't afford things like that. So somebody has to quit and stay home and take care of the person that's showing dementia symptomology. Going to appointments, we found that out with our clinic too, that it's hard for people sometimes to take off in the middle of the day to come to an appointment because they work in jobs that they don't have personal time, or what do they call PTO time. So it's time without pay. And if you're working at a factory or a restaurant or a hotel, that you have to take off 3-4 hours to take your parent to a memory screening appointment or to see the doctor, that can get a barrier. They can put it off, things like that. Or as we find sometimes they send somebody else with the grandparent for the screening, sometimes a high school student or a grandchild who knows nothing about the history, things like that, because they don't understand that you need an adult. So the time of going to the appointments has been a barrier. Geographical barriers too. Again, not every county, not every in Wisconsin has memory clinics to begin with, diabetes memory clinics, much less Spanish-speaking memory clinics. So that's a barrier too. Even if somebody wants to get the parent tested or diagnosed, they might have to drive an hour, 2 hours, or have to drive to Green Bay or Madison for something like that. And do they really want to do that? Transportation can be an issue, reliable transportation, if you get them there and back safely. And I go back again, the lack of proper screening sites. There are memory clinics, there's quite a few memory clinics in Wisconsin. And many of them, when it comes to Latino or other languages, they rely still on the interpreting services or something like that. And that just gets in the way of a proper diagnostic process when you're using interpreters. Even the tools that are out there, they're not always appropriate and written for the level of literacy, you might say, or for the different cultural innuendos from different countries. That most of the tools tend to be very American based and very high school level, you might say. So they're out, so we're having trouble with that. They're getting better. There's more tools being out there tested and being used. We're using some here that have been adapted, but that can be a barrier too. And we just don't have enough research done in the Latino population about dementia. We're just missing at the table. And it goes both ways. Researchers aren't reaching out to the Latino communities, and Latino communities aren't aware of the value of being involved in research. Then the other one too, I think that gets in the way, we see it here too, is the mobility of families because of the work they're involved in. And Brown County, you know this, you have quite the migrant population, and the county next to you. You have all the people that come in and out, they follow the crops, they're here for this spring through fall, and they disappear, go back home again, right? And if you're just starting a process of doing an assessment or getting services going and they disappear, you don't see them again. Or they move job to job, or because of financial issues, they're moving from home to home. So the mobility is an issue. We have a problem to do follow-ups with our families and patients here. Something that gets in the way. I want to touch on this because these are like norms or influences that I believe impacts how we view our health as Latinos. And again, as Latinos is a catch-all, but we're various countries. We're not just one, we don't represent one country and one culture. But some of the things that we do tend to have in common is the emphasis, the high value that we put on la familia, the family. Putting our family first, putting our children first, doing what we need to do within the family, helping each other as family members, as a collective group. I can't say enough about that, and that's been a you might say a what do you call that, Virginia? It's an asset. It's a health asset, right? It's something that can get you through bad times because you have family to fall back on. But it can also be a barrier because there's a tendency to want to keep things within the family when something happens like dementia. We'll talk about that later. Religion. Not everybody's in the same religion. We have Protestants, we have Catholics. There's all sorts of religions, but the religions communities tend to hold things together. For generations before social service programs were invented, this is what helped communities, was falling back on the church, on the service and support of the church. And there's still a very strong religious presence and value in our communities. Holistic medicine. We have many older adults and first generation people that still practice this. We have quite a few curanderos, maceros in our communities that are still practicing, and our patients, our families are still going to them for healthcare and relying on holistic medicine. The thing what binds us together is el español. It's the Spanish. It might be a little different dialects, but it's that language that connects us as a community. So that just wanted to touch on that it's more than just the health issues that also impacts our health. It's also how we perceive the world through our norms like this. Get a drink of water. I'm going to touch on this because these are other norms or influences, you might say, that shapes how we look at health and health prevention as Latinos. You might have come as a refugee. I don't know if you can see my little arrow here. If you come as a refugee to this country, like it's happening now, right? Or from Cuba, you're automatically eligible for all sorts of benefits, aren't you? You're available for government support service because they recognize you as a refugee. So if you're having issues with healthcare, you can get healthcare services, things like that. Uh, we also come here as migrant workers, whether from other countries or locally, coming in and out from various states. So not staying long enough really to get health care if you're dealing with it. You tend to get your primary care back in your home community or home state. And tend to work in fields and type of industry that exposes them to health risk, health factors. Who knows the chemicals that they're using in your community, things like that. And unless you happen to be in a community that there are organizations that reach out and provide health care to migrant workers, they're kind of left, on their own. And I speak from experience. I'm a former migrant worker. We travel back and forth from Texas to Green Bay, Oconto, Kiwani, and we had those health issues that pop up. We didn't know where to go, so we just kind of took care of ourselves. We had a curandera in the camp, and she took care of us. But that's something, and it's hard then to follow through with care. People might have come here for school, so the higher educated group, and they're the one, and they'll stay here, so they they have better knowledge how to access care, how to use the internet, things like that, and are not afraid to ask for help and advocate for themselves. We have people that came from other, when they were back when I'm going to use World War II as an example. We had quite a few Latinos, a lot of Latinos who signed up to serve in the military, both citizens and non-citizens, because they saw that as a way to become citizens, and they stayed here after the fact. Okay. We also have groups that migrated here because of the airline industry. We saw quite the influx of Puerto Ricans coming to the United States, especially Chicago, eventually Milwaukee, because of the airlines having direct flights out of Puerto Rico that didn't exist before. The most of the migration for the Puerto Rican population was along the East Coast. But now Puerto Rican communities all over, but the airlines were a big factor to that. We have people that, and Puerto Ricans, because they are American citizens, are eligible for Medicaid, Medicare, food stamps, et cetera, compared to the population that came, that I'm going to talk about next. They might have worked here or working here, they are undocumented, were brought in to work in the factories or the meat packing companies, the tanneries, the Hillshires outside of close to Green Bay there, that may or may not have been documented at the time they came. So they may be getting some healthcare access there if they're eligible citizens, but if they're not, they may not be eligible for the government supported services if something goes wrong and they have to rely on public benefits. The other thing to remember, and I put Texas in there, that's where I'm from, but just to remind people that we're not all immigrants necessarily. Like some of us have been, our family's been here like 500 some years, so we don't consider ourselves immigrants. We are American citizens, but we have also encountered some of the same barriers to access to services and education and opportunities like our immigrant brothers and sisters. I came in at the tail end of my grade school years to still see signs like this down in South Texas, at the grocery stores and gas stations, things like that. So discrimination was just as prevalent for our population as it is for the immigrant population. All that can affect you when you're being approached to say, can we offer you these services? Would you like to come in? Can we come to your house to talk? If you've had bad experiences or didn't have that kind of open knowledge about healthcare and prevention or equal access to services and didn't face discrimination, yeah, you're probably more open to it. But if you've seen those kind of experiences, it's going to make you think twice and say, no, thank you. We'll take care of ourselves, or not answer your phone calls, or not come to your workshops, or come to your webinars and things like that, because of the prior experience we bring into our present view of the world. And I'll be willing to take questions on that one, comments, when we get done here. We also have the terminology and the viewpoint about aging. Just like in any other population, the word dementia is still not a positive connotation to it. Especially for us, it means demencia in Spanish, which we refer that you're crazy. There's something wrong. You're mentally ill. So, for example, when I took this job over in 2007, I think it was, I inherited what was called the Latino Dementia Clinic. And we changed that within 3 weeks. There's no way we're going to use dementia clinic. Okay? So we call it the memory clinic. It's a little better than dementia. But just that itself can just create a barrier right away. And just like other populations, we tend to poo-poo the signs of aging. the dementia as signs of aging. I'm sorry, that's just normal. It's just a abuelito. It's going to happen. Things like that. I talked about. I mentioned this before. That language and literacy level has to be accounted for when you're providing information about dementia out in the community. Not everybody speaks Spanish. Not everybody can read at the high school level. Not everybody goes to social. Not everybody uses Facebook. I mean, Lisa mentioned that before about the preference to keep things in the family, which is, again, it's an asset. It's a strength. Okay. But it can also get in the way when the need is really there and people are hesitant to reach outside the family. Just like in other cultures, there's also the roles and expectations. The gender roles, I think I might have my next slide too, is, and Virginia can see this too, Martha can see this too, Blanca, that the expectation is something like this happens, you look at the daughter to step in and take care of the mother or father with a dementia. And if you're the oldest, it sucks to be the oldest or the youngest daughter, doesn't it? The ones in the middle get away with it, but somehow we think the oldest daughter because she's the one that's next responsible, or the youngest. She's young, she got her whole life ahead of her. She's not married. She can move in and take care of grandma, things like that. And the sons get off scot-free most of the time. We're seeing a change in that though. We're changing it. We're seeing more and more Latino men stepping forward and being involved. Virginia knows that we have some caregivers in common. They're just awesome Latino caregivers. But there's still that gender role and that cultural difference in our culture. We also have that feeling that we don't want to be a bother to it. We don't want to burden others outside the family, okay? Which is okay up to a point, right? But if the family's burning out or you only got one caregiver and he or she's burning out or the schedule changing their job, it can create quite a social and emotional and physical burden on that caregiver. I want to touch on documentary, I said that before, which can lead to outside help, resistance to outside help, or just not trusting or not sure. We'll think about it. We'll call you back, Virginia. We'll talk it over. We'll let you know, right? And then 2-3 months go by, things like that. We may not think we're from the government, but if you come from a country where only the government provided services, you may be a little wary of that. But also, if you came from a government that was corrupt and they always expected a mordida, a bribe, to get services, to get to the head of the line. Some of our older adults kind of come from that mindset. That what's this going to cost me? What do I have to do? Things like that. Respect for our elders. This is a big one. I mean, it's a positive for us. We value our elders very, very much, our abuelitos. UCC, we dedicate a lot of space and time and money to them. We respect them, respeto. But that can get in the way because if, let's say the doctor wants to have a conversation with the grandmother and with the daughter about grandmother's symptoms, it's really hard for daughters and sons to tell the doctor what's really going on or even speak up in front of their parent because it's a form of disrespect or deferring to the mother and father who's having some serious memory issues and behavior issues. But if he or she tells the doctor, no, está bien, doctor, I don't want that help. The son and daughter say, well, we got to listen to what they say, even though they might agree with Virginia or me that, yes, they need services, they need daycare, they need an assessment. If the parent says no, then the son and daughter will back off because of that deference, that respect that we have for our elders. Depends on the level of acculturation. I don't do that. I drag my dad where he had to go, okay? But I'm very acculturated, okay? So it's a difference that I think those that are not Latinos need to be aware of when we're trying to talk services. Got to find a different way to backdoor, side door those resources without being disrespectful, you might say. And I mentioned the prior history of prevention in their countries. Talk about assimilation levels, fatalismo. Many of our older adults and very religious people still believe that it's God's will. What's going to happen? We pray to God and God's going to get us through this, or God willed it to happen, or if God is willing, we'll see what He says, things like that. Which is okay in most cases, but if you're dealing with a serious health issue, sometimes God needs some help, right? But it comes up once in a while, and they can put off also making decisions. We try to talk about power of attorney, healthcare, right, Virginia? Sometimes it comes up, it's a difficult conversation to have. Well, we'll pray on it. We'll see what God will tell us, things like that. I already talked about work and the gender roles and caregiving. I'm going to slide into how we're responding to it. As Virginia mentioned in the introduction, in 2007, we started serving the Latino population around dementia. We'd already been doing elderly services before, but we started seeing issues of dementia and how to respond to it. So we've developed what's what we call a continuum of care. We are now, our process is getting out there and identifying early people, the symptomology. And that can lead to earlier detection then, which can lead to earlier clinical evaluation, which can lead to then be able to provide, help the family develop a plan of care, of services informally among themselves. And then as the dementia progresses, we know help them develop formal support services into the door. And that's done through community outreach that we do. Virginia does a lot of that with us and helps us with this. And until the pandemic hit, we were able to do in-home memory screenings through the team I'm going to talk about in a few minutes, which can lead to a memory clinic evaluation for a diagnosis, which then we can develop a formal plan of care with the family members, offer services like our senior center program for MCI people or for the caregiver that doesn't have dementia. If there's a need for long-term care support services, we have our own family care unit here, My Choice Family Care Unit, that we can refer to. And as Virginia mentioned, we have a day center that specializes in dementia for Latinos, Latino Geriatric Center. And then our care managers can then also facilitate moving on to CBRFs or nursing homes. So what we're able to offer now is a spectrum of care as depending on the stage of the cognitive impairment that we didn't have before. We do this by the Geriatric Center we established in 2007. We did that in partnership with the Alzheimer's Association, thank you, Fredo Medical College, UW-Wisconsin's Alzheimer's Institute, and us. We opened up the memory clinic, the day center at the same time because we were seeing our seniors in our senior center program and our housing developing symptoms of dementia that we couldn't handle, and we cannot send them anywhere else for formal diagnosis and services. So with like 2 years of planning, we into this and to developing these two programs. And started slow, but now we have been functioning and not meeting everybody's needs yet, but we pretty much focus on Milwaukee County at this point. And I'll talk about why I mentioned that because we're looking to expand after that. Our clinic does not charge for the assessment for the family meetings ahead of time and the initial assessment. We eat that cost through foundation grants. What we do charge for is when the doctor sees the patient and he charges the insurance company for Medicare or Medicaid. We are able to see undocumented people, but only one per clinic. That's the agreement we have with Fredo Medical College to let the doctor see one uninsured patient per clinic. And after clinic day, we connect them directly with Virginia. Pre-pandemic, she sits here with us, drinks our coffee, and waits for the diagnosis to be done. And we do the warm handoff. Right? We found that model works very, very well. Right now, we're doing telephone and virtual handoff during the pandemic, but it just helps so much to have people like Virginia at clinic day. So you're not wasting any time, and you get that personalismo, that personal contact right then and there before they leave. Highly suggest that in other clinics to have somebody from the association present. We've had to adapt as time goes on. We started in clinic services, 2007 to 2008 was all clinic-based, which means the families came to us, the patient came to us, and we were finding that so far it was meeting the need, but we're also getting calls and letters from primary doctors and including our own staff that families were not, the patient was not coming in. They refer them and they would not come in. 3 months would go by, 6 months, and then things get worse. So we looked at the data and we found quite a few of the no-shows or people refusing to be screened or not, or bringing their family member in. That led to 2019, through a federal grant, we got to pilot what we call a mobile memory clinic model, where we were able to train the nurse and social worker to go into people's homes and do the actual screening in the home safety assessment, and we do the interview in the family in the home, and then start plugging in services right away, not waiting until the clinic day. That was working pretty well. And then they would come and see the doctor like 4 weeks later on clinic day. Pandemic, of course, shut everybody down like us. So we had to pivot quickly, turn quickly to something else. So we converted to a telehealth model, which is what we're using to this day yet, where instead of the team going to the home, we deliver a Chrome tablet and a hotspot and a microphone and earphones to the homes before the appointment. And then the social worker by telephone walks the caregiver on how to use the equipment. And then the appointment starts. They'll do the assessments virtually. And then at the end of the appointment, go back and pick up the equipment, sanitize it, bring it back, and get ready for the next appointment. Then when they're ready to see the doctor, the cycle repeats itself again. The worker goes out to the house, drops everything off. By the time he gets back, the doctors on the screen, talking to the patient and the family members. So we're doing the diagnosis process until I think about 2 months ago. We're starting to see patients in the clinic with COVID protocols in place, prioritizing the ones that have been waiting during the pandemic to be seen. And then we also develop a virtual family caregiver class along with Virginia and Dr. Antuano and our staff here to also now offer caregiver education series, 4-session series to caregivers in Spanish. Half is recorded and the other half is discussion, questions and answers. And that's where we are at this point. We've also gotten to a little bit of research on the site. As I mentioned before, we're missing at the table in research. So we've done some research projects in the past number of years with medical college. We tested a behavior activation model where we're coaching caregivers how to take care of themselves better using behavior activation technique that's not mental health treatment, but it's designed to get the person accustomed to taking care of themselves and monitoring themselves and getting self-rewards for that. We're just wrapping up. Virginia was involved in this. We're wrapping up an NIH grant, Alzheimer's Care Managed Minority Groups. We're interested in seeing what those crisis points that gets a Latino and African American family to turn around and accept outside help. When is it time to accept formal help outside of the family system? But we also have interviewed the health providers from their perspective and the social service providers, what they see as crisis points and how caregivers respond to crisis points. So we're just looking at the data right now, but it's pretty interesting at this point. We're starting to see a difference between the Latino and African American population, defining crisis differently, but also the providers believing that the Latino and African American caregivers don't understand the symptoms, don't see the symptoms. And yet when we interviewed the caregivers, they recognize the symptoms. They just didn't have a name for it. There's some miscommunication going on between the providers and the caregivers. And that's what we're trying to uncover in the study. The plan is to then develop some kind of a guidebook, a toolkit that providers and caregivers can use so they talk the same language as the transition of the disease develops. This is the project we're just wrapping up for Latino Fuentes that Virginia's been involved with us also. This was a federal grant that we converted a memory clinic to be mobile, family caregiver classes, teaching our staff better skills on managing people with developmental and intellectual disabilities, ID and DD, that have dementia. It's a community-led project. We're in our last week of it. And so the next 3 months, we start looking at the data and see how if that was an effective model or not, or what parts was effective that we could replicate elsewhere. And these are services we're going to refer to. Senior Center we have, our family care program. We do have a shared space with the 16th Street Clinic. It's our local federal qualified health clinic on site, which works nicely. We share the space with them when they're not using it. So we can do it and we can refer internally to each other. And we can do it with our good buddy down at the bottom, the beautiful Virginia Zerpa, who's our right-hand person here. What's next? Once pandemic settles down, we go back to mobile memory assessments. We've submitted a couple of grants, state grants here, foundation grants, to take the telehealth assessment model and be able to offer it among the 4-county region down here, where the heavier Latino population is. And who knows, someday Brown County, right? If we get funded. And then, of course, keep expanding other opportunities to get Latinos involved in research. With 5 minutes over. That's my presentation, and I open to questions and comments. Thank you.
So if anyone wants to unmute and ask questions or comments, it's a small group, so feel free.
Yes, hi, this is Marta. And my question is for the adult care, you only accept people with dementia, or is for any older senior?
Good question. We're licensed for dementia, physical disability, and developmental disability. So they can have other health issues. Yes. Our specialty is dementia, but we have a lot of people with other health issues. They're always related. There's more than one. Yes.
Okay.
One more. Not skilled care. They cannot need skilled care though. That's nursing home level.
And to qualify for that program, the person has to live in Milwaukee.
It depends. They have to be a client of the My Choice Family Care program of Milwaukee County, because that's who our contract is with. However, it does not stop another family care unit from Waukesha or Racine to send somebody here. We contract with them individually. It's just that they'd have to provide the transportation to get the client here. We provide transportation within the county, that's our contract. We cannot drive to Waukesha or Racine. But no, there's nothing stopping a Racine ADRC from contracting to send a patient over here. And that's the one that I mentioned. You do have to be eligible. We can't serve undocumented because it's very expensive and we can't get reimbursed for that. And that's the barrier that we're running into. Private pay, we take private pay. We've had private pay patients here before. We've had doctors, we've had nurses, we've had professors who can afford the private pay rate. But the majority, 90% are low income.
Thank you.
Other questions?
Hi, this is Blanca.
Hey, Blanca.
I have a question. You said that for your clinics, you are able to see one uninsured patient per clinic. And how often is that?
Clinic is 2 times a month, 2 Mondays a month.
So
basically,
basically
month.
2 per month. Okay. And also for your telehealth right now, that's only for Milwaukee County?
Actually, we can screen anybody telehealth wise. If they have the right ability on their end, that we don't have to drive to Madison to drop off the tablet. They can use a smartphone or they have a laptop and they can do it. That's great. We've diagnosed this past year, people in Puerto Rico, Mexico, 2 in Madison, 1 in Green Bay, Kenosha, Lake Geneva. So if they got the equipment on their side or our organization help set up the equipment, we can do the assessment.
Okay, thank you.
Hi, Al. This is Bonnie Beam-Stratz.
Hi.
Quick question for you. I mean, I covered now the 4 counties in Southwest Wisconsin, and probably the next largest population, and it's still very minimal, is the Latino population. But I was curious, so if I should work with someone like in Lafayette County, and they're needing an evaluation, who would I contact? Would I just go directly to UCC for making a referral, or?
No, there's an informational flyer. I can share it with Laura, and maybe you can send it around. We have an intake referral form you can fill out, or there's a flyer that goes out with the number to contact the memory clinic, and that's how we process it.
Okay.
It wouldn't be.
Do you know if there's? I'm sorry.
I said it wouldn't be me. There's a different phone number to call.
Okay. Do you know offhand if there's any services in the Rockford area? Because that would be a little closer for people living out this way.
I'll defer to Virginia. It's out of my region. Not a Spanish-speaking memory clinic. No.
No, not a
Okay.
Spanish memory clinic, that's correct.
All
I
right.
know, Bonnie, this is Corey, and I know I
Yeah.
had searched for one also and could not find one
Okay.
for
thank-
consumers in Janesville.
Okay. And I just had one other question, Al, when you were talking about the increase in numbers in the population, do you think some of that could be related to more people reporting to surveys? Or do you think there's still a lot of that fear?
Increase of number because we make a lot of babies. We tend to be big families. Plus, family brings family, brings family, brings family, brings family, brings
Okay.
family.
And also, if I may add,
Yeah.
they say that the increasing also the Latino populations in Wisconsin also now is coming from other countries. Now, even Venezuela,
Yeah,
the percentage of Venezuelans coming to the United States, but here in Wisconsin has increased. So there are other Latin American countries that are contributing to the increase of Latino population from the last decade.
I was just curious because I know when I was working in Jefferson County,
Yes.
there was a big push
Yes.
to get more people to report, for services and everything. So that's why I thought I'd ask that question.
Historically, like Virginia said, people coming not just from Mexico and Texas anymore, from other countries. One is the dairy industry, those big mega farms you have, those big 2,000 to 3,000 cows, things like that. You need people 8 hours a day, 24 hours a day, 365 days a year, right? You can't get the local workforce to do that. So there's quite an influx of younger Latinos from different countries in Jefferson, Walworth County, probably even more, the Stevens Point area. So these are young families that bring a lot of kids, and then they bring their family members. So you get that snowball effect. We're not seeing as high of an older adult population yet. Okay, it tends to be the working age. That's who's coming here. And it's all around the country, but in Wisconsin, because of agriculture industry. And then you have the meatpacking plants, Hillshire. We got the ones here, Patrick Cudahy and Clements, things like that. Again, recruiting from those parts of the country where people will come and do this, the nasty, sticky, dirty work. And at that time, not good benefits. But now what's happening, I think, going back to your question, I think this whole past year, what's happened was all the social unrest and everything that's popped out. I think organizations and businesses and healthcare industry are strategically and purposely saying, yeah, we've been part of the problem. We need to do a better job of reaching out to these minority populations and take care of their needs. So I think that's a combination of that too, that I don't want to call it the guilt trip, but it's a social responsibility feel that's happening around the country that, wow, we didn't realize that we could contribute more to the solution instead of being part of the problem. So I think it's a combination of all that happening. But I still go back to, we have big families and we come to do the work that nobody else wants to do at the wages and the hours, and we stay. We stay.
Thank you.
Hi, this is Corey Marsh, and I have a question. Do you have any suggestions, either yourself or somebody else, on how to support that youngest daughter who gets absolutely no support from the other siblings? When she's been appointed and she's got a young family of her own, I actually have 2 different women that I'm working with that are exhausted because they are both breadwinners for their families as well. And so they're trying to work, 8 hours a day and take care of their own families and also provide hours and hours and hours of caregiving services as well. And they're tired and they beg their siblings for assistance, and they're just not getting it, to the point where, her 12-year-old daughter is also lending the caregiving, and now she's feeling like she's relying too much on her 12-year-old daughter. And that's bothering her a great deal as well.
You should. I'll let my buddy go first. Virginia, how have you handled that? I don't know how I've done it, but you go first.
Well, does she qualify for, do they qualify for services to in-home care or, so because then I will connect them with resources.
Yeah, they have all of that, and mom and dad won't accept any of that. That's her job.
That's her job. She's the youngest. She's
So
the youngest. That's why
they
God
will
put her
not
here.
accept any of that. That's been offered time and time again.
Yeah.
She's attempted. It's just her siblings don't feel that it's their role to have to step up and help. They say they will, and then they don't. And so then she ends up having to change her plans at the last minute. And her plans are things like trying to go to a support group or trying to get the grocery shopping done, or, it's not like she's got grandiose plans. She's just trying to get her household, keep her household functioning.
Yeah, every family is different. And I've run into that several times, especially with real macho older brothers.
And that's what they are.
Yeah. Sometimes if they use the thing that's her role, that's what God put her here, things like that. I always remind them, well, didn't God rest on the 7th day, when he created the earth, so God got to rest, your sister needs a rest too, things like that, if they want to use that angle, right? It worked a couple of times. But in
If you don't mind referring them to me as well.
The angle is, if your sister has a nervous breakdown, right, and gets sick, okay, we all know that what happens with caregivers if there's no break, right? You just walk them down that path. Okay, I hear what you're saying, she should be, but you almost have to coach. That's what we did in another project. I coached the family, the caregiver, what to say to the family. They actually practiced in my office what they were going to say before they went to say it. Depending on what they were saying. So whether it's my heart's going to give out, or whatever it's my diabetes, or my marriage, or whatever, that basically we're going to say, if you disappear out of the picture, which of you is going to take care of mom? Okay. because the brothers and sisters that aren't there, they don't understand the day-to-day, right? But they know that if sister's gone, which one have you got? And if not, that means she'd have to go to a nursing home after all. That's the last thing they want to do, right? Put her somewhere. So trying to turn that conversation around. Yes, I'm doing my best, but if my heart goes, whatever it is, I'm sure she has health issues, right? But she can kind of exaggerate that, you might say, because really it's going to happen. And if
Yeah,
something happens to
it
her,
definitely could.
yeah, then which of you is going to step in for me? And if not, she's going to have to go to a nursing home. And that's the last thing we want.
Right.
Then try to negotiate something in the middle. Now that cake, then who can help me on a Wednesday or whatever. But it almost have to be that they have to feel the anxiety that, oh, I never thought of that. What if I have to step in? What if my wife has to quit her job to stay here and take care of mom, things like that. It's the reality that's going to happen anyway. So if you can just, we call that in social work prescribing the problem.
Yeah. So that's a good idea.
Yeah. Sometimes
To
that
try to
works.
support her and coach her through some things that she could try in communicating with her.
Sometimes there might be a sister or another relative who can be her advocate, so she's not alone talking to her family members. Might be you, but sometimes so she's not alone when she has the conversation. The conversation.
Yeah, and I know her husband has tried to be that person, and that's not the right person, because that turns into not good. Because he goes into protecting his wife, and that ends up not being the right.
Exactly. And then there's always the professional. There's always the doctor.
Right.
And the doctor meet with all the family.
Yeah.
Our doctor does. Or is there a minister or a priest that the family would have? You know, we call them credible messengers. Who's that credible person?
Right.
That they would listen to, that would reinforce the sister without breaking up the family.
Right. Okay.
Somebody who's got skills and has respect and credibility. And somebody, this one, again, if they're religious, if they're involved with the church, and if it's the doctor in the white coat.
Because I don't really think in this case I'm that person.
Yeah, and
I just culturally, I don't think I'm that right person to take on the brothers. I just don't think culturally I am that right person.
No. And that's
so it's trying to support her, to try to, help her in what she can do. So
sit down with her and do a little sketch.
Because I don't have the white coat and I don't have,
Ask her who's in her little world that would be that person that could be her advocate. And may not
Thank you.
Might be somebody that you haven't thought of, she hasn't thought of yet.
Yeah, great. Thank you. And thank you for what you said as well, Virginia.
I'll jump in real quick. I put a link for our evaluation and sign-in sheets. There's an opportunity if you want a certificate for attending. But also, if you fill that out, we'll make sure that whatever Al forwards to me, I can make sure I get to everyone.
Yes. You can know that, so I don't forget.
Any other last comments before we end?
Maybe you said something, but Al, are you going to be sharing the slides?
Yes, I already sent it to Laura.
Okay.
Yep. So I'll send that out, and I will also send the recording.
Great.
So just make sure you sign up.
And thank you so much for doing this. I wish more people had heard it, but hopefully people will get a chance to listen to the recording or something, because it was excellent. So thank you so much.
We've been talking about putting this series on our coalition page of the recording so that they can still be accessed. So
great.
And from my heart, thank you for the work that you do in your respective parts of the state. We need this in our community, this kind of information, and the kind of work you're doing for whatever population. Dementia has like a ripple effect. So I appreciate what you're doing. And from a personal note, Virginia knows this too. I went through Alzheimer's 3 times in my family: my dad, my mother-in-law, and my uncle. So being Latino, it's even more of a passion for me. So appreciate the opportunity to share this with you, and hopefully you pass it on and keep asking the questions and keep asking people to think outside the box.
Thank you for everything.
Perfect.
And I think Blanca and me, we're going to bother you with more questions later.
Estamos para servir.
Okay, thank you.
Okay. Thank you very much, everybody.
Thank
Thank
you.